everybody. I will wait a few minutes for people to join. I'm a couple minutes early. Um, so we will give it a quick minute. If you have questions or comments, please go ahead and enter those. Good morning. We'll get started in just a minute. Give some people some time to join us this morning. Those of you that are joining me, go ahead and put in the comments where you're joining from and what your name is. Well, I guess your name would be on the thing, but go ahead and let me know where you're coming from, just so we can see where we have people joining from. Hi, Leah. Hi, Deb. All right, we'll go ahead and get started. My name is Kim Hall. I am a newer team member to Team Bud. I joined a little bit just because I work on call at the hospital, just kind of help collaborate and learn. I'm still considered a new dietitian. Been a dietitian for a little over a year now, and I work at one of the larger health systems, primarily here in the Pacific Northwest. I finished my internship during the pandemic, started in January of 2019, and had a bunch of my internship stuff jumbled around due to the pandemic and the changes to people having students in house and restricting visitors and that kind of thing. A little bit about my background. I was born and raised in Michigan, close to Lake Michigan. I grew up in a farming family. Up until a couple of years ago, my great aunt and uncle still had a dairy farm. Nearly all of my family, actually, on my dad's side, had or has a dairy farm. So I grew up around cows on farms. Lots of fun stuff there. You learn a little bit about, where our food comes from and the struggles that farmers can go through to really get adequate pay for their work. It is a hard job that not a lot of people really want to do. I graduated from Western Michigan University with my bachelor's in dietetics. Feels like 100 years ago, but about 10 years ago. And then I moved into food service management from there. So I worked in long-term care, learned a ton from my managers there, really learned to see the bigger picture and kind of work on that. I did that for a few years, realized that was really not my passion. I really love the geriatric population. I love that in the long-term care setting, you can get to know your residents. You can get to develop those relationships and that rapport over a longer-term basis. And I'm super passionate about making sure people in the last years or days or weeks of their lives have some dignity, and they're treated with respect and treated as a whole person and not just a collection of diagnoses. Remembering that these people didn't always choose to be in a nursing home, but they still deserve to be treated with respect and to be loved, and to make sure that they are given the best that we possibly have. Sorry, I have a fly in here. And then we made the move with me, my husband, and my son at the time to Washington. My sister-in-law lives out here, and we decided to move out here for something different. So came out here, worked for a couple of years as a tech in a hospital, more long-term care, but more as a diet tech. And then I finally decided to do my internship. So I had applied in 2017 as well as, and then didn't match. And then in 2019, I was matched with Keith and Associates out of Tulsa. They're a newer program, but they take a lot of interns, so I highly recommend them to people who have a varied history. I had a lot of experience, but I didn't have a lot of clinical experience. So it was helpful to kind of use that background as kind of part of my resume, so that it was more than just my grades that were there. So I highly recommend them. Patty over there is great. They are really concerned with their students doing a great job and being well prepared. So I completed my internship, like I said, in the beginning of the pandemic. It was interesting. So I had flown to Tulsa for an orientation, flew back, started doing my rotations. I was in a diabetes clinic for a couple of weeks, and then I started doing my clinicals. And in the midst of that, I was supposed to do a couple weeks with a dialysis dietitian here in Tacoma, and they shut down everything a week prior to me being able to go there. So they closed off their clinics to everyone but essentials. I think even the RDs were working remote, their social workers were working remote. So that left me without that experience, which I've kind of sad about missing out on. I was excited. And then I did my clinicals, where I had been a diet tech for a couple of years already at Multicare. And I love the group there. There's we have like 40 dietitians, I think, that are underneath my manager. And it's really great to learn from them and get some more experience and kind of hear the conversations about what's important and what's not important in the acute care setting. And I learned a lot there that I think prepared me well to take my exam. Beyond that, like I said, I've been a dietitian for about a year, a little over a year. And in that time, obviously, we've dealt with COVID for, 18 months now. So that's been an interesting learning curve, because we can't go see as many patients. We can't get hands-on with as many patients. And I think that's an important part of our discipline and part of our profession as a whole, is really getting to interact with patients. And so for us, being non-essential to personal care, and having to do, the day-to-day, like meds and those kinds of things, making sure the patient's clean, all that good stuff, then we were kind of relegated to our offices for a lot of care for those patients, which is frustrating. And the volume of patients. We have so many patients. We're in our 5th wave now. And it's kind of demoralizing to get such a high load of patients that you can't possibly do a great job for all of them. And it's something that I'm hopeful will return to somewhat of a normal. I don't think COVID's going away anytime soon, unfortunately, but I'm hoping that we get to more, either better staffing ratios or to a more manageable load. because our census for patients that we're seeing daily at the hospital that I primarily work at is 20, 30, 40 patients above what normal is, because we have so many vented patients, so many people that are very ill who haven't sought care in 18 months and now, haven't had that cancer checked or haven't paid attention to their health care because of the fear that surrounds, getting sick and getting very sick. I will, Leah just posted a question. If there are dietetics listening who haven't thought about being dietitians, or who have thought about being dietitians but just haven't taken the next step, what advice would you give them? So my journey was very long. I waited about 10 years before I actually did my internship, and it took being comfortable in a space and kind of understanding and being in a place where my kids were old enough to not need my attention 24/7. But I think just being realistic about the options out there, choosing an option that may not be a great fit for you, but is something that can help you grow and help you get to where you want to be. Keith and Associates emphasis is on entrepreneurship. Now, do I see myself opening my own business at some point? Probably not. I enjoy the clinical and acute care setting, and that doesn't really lend itself to a home-based business. But I still learned a lot, and I still got some great information and, build my my view about the profession of dietitians as a whole. The dietitian that I did my entrepreneurship rotation with, she was a Hays dietitian. And for me, working in acute care, we don't really pay attention to weight so much unless people are underweight, right? Or there's a big weight change. So for me to kind of hear her perspective on things and hear how she approaches people in that setting was really interesting. And I really learned a lot about my own biases and then how to kind of approach those in the acute care setting, which was interesting. Next question from Leah is, when you're able to see a patient, do you have to be in PPE? Absolutely. We are, as of right now, are not going in to see our airborne or droplet precaution patients, just as a general rule. They are starting to pilot having our food service employees deliver trays to those rooms, those people that are eating that are still in airborne or droplet precautions. Excuse me. But to even hit the floor. So as soon as we leave, we have to be in masks 24/7 at the hospital, unless we're eating or drinking. And then we have to be in a surgical mask or an N95. And then when we go in a patient's room, just any patients, we have to have eye protection. And then beyond that, it's just the standard different precautions that we have in the hospital. So the contact precautions where we have to wear a gown and gloves, enteric where we have to wear a gown and gloves, and then wash our hands on the way out with soap and water instead of the gel. And then the droplet and airborne we're not moving into just yet, but when we do, it'll be an N95 will be required. We're in the process of getting everyone fitted right now. So we do wear some PPE, which is difficult with especially our hard of hearing and elderly patients, patients who don't wear masks in the community. So it's difficult to get them to comply because they are supposed to be wearing masks when a staff member enters their room. And a lot of our hard of hearing patients have a really hard time hearing behind our masks, let alone not being able to lip read or get the whole body language thing, because half your face is hidden. So it's sometimes difficult to communicate with those patients. So you have to get creative. There's been challenges too in COVID with tube feeding is getting physicians on board with best practices. And yes, we still can feed them if they're prone. Yes, we can still do, a lot of different things. So, and then finding out, with patients who are on high doses of paralytics or pain medications or those kinds of things, who are very, very ill, their guts often don't work great. So getting them to get some nutrition, so we're not completely depriving them of nutrition, is important, and to keep their gut moving, keep it alive, and not cause more complications that way. It's kind of been our primary focus. Another question is, we're hearing in some of our groups about shortages of various nutrition-related supplies like tube feed and vitamins for tube feed. Gatorade, are you seeing this? We are definitely seeing this. In the beginning of the pandemic, we were kind of told to prepare for tube feedings and just kind of over-order things just to make sure. Because with our tube feeding formulas, we use Nestle products in our facility, but they are, there's only a few that are high calorie, low calorie, high protein, so that we're getting the maximum amount of protein that we can to these patients. We then, towards this last wave of people, it's been so severe that we are having a really hard time getting hold of tube feeding the most appropriate tube feeding when we need it, when we order it, because everyone is experiencing the high volume things. We were out of, or had a limited supply to multivitamin additives for TPN. We outsource our TPN compounding to a local pharmacy, and they compounded in all one bag for us. But if we don't have the multivitamins in their long-term TPN patient, it makes for some trickiness, for sure. We haven't had any really issues with PPE or anything like that. Getting the right pumps has been an issue. Making sure we have enough pumps. I think right now we have like 50 plus people that are on the vent. So making sure that we have pumps for all of those people. Making sure that we have the protein modulars to get them more protein for less calories. I had a guy a couple weeks ago who was on like almost 50 mils an hour of propofol, which is about 1,700 calories a day. And so meeting his needs, we were overfeeding him in kcals, but then we weren't getting any protein. So trying to get things just to keep his gut alive, because we were not going to meet his needs as far as protein was considered. Another question, if someone is new to clinical acute care during COVID, are there resources you would suggest to get up to speed, learning more about working with these people or with these patients to provide appropriate nutrition care? I think it's just, asking those questions of the people who have dealt with this, the ICU dietitians who have been in the mud, I guess, over the last 18 months, because it's really about, they're noticing trends. They're noticing what works well for them. They're noticing what struggles in their particular facility, which providers they have to convince of certain things, or different things that the providers are willing to go for. Also, Aspen has been a really great resource. They've done a great job of kind of compiling the latest research and the latest information and guidance as far as that's concerned. A lot of it has been trial and error through the last 18 months, and kind of getting to the point where realizing that we are not going to meet their protein needs all the time, but that we're just really trying to keep their gut alive. So we've been doing 10, 20 mils an hour for days, trying to get them to at least just, have gut function. But their primary goal is making sure they can breathe. They're making sure that they can get air into their lungs. Um, there was something else I was going to say, but I can't remember what it was. um, I think the biggest difference for me, I worked in long-term care for a short time right after I became right after I passed my test. I was back in long-term care for about 8-9 months, and we had COVID hit our building during that time, and it's insane to quarantine all of these patients. We had several patients die in that time period because it was prior to the vaccine. This was in December, where the vaccine was just getting rolled out. We didn't have any of our patients vaccinated at that point. And trying to get, nursing on board of, it's really important that we wear a mask in the community, that we keep ourselves safe, that we do the quarantining if need be. I ended up getting COVID at that point because a nurse brought it into the facility. And thankfully, I didn't have any respiratory symptoms, but I felt terrible. It was awful. I did not get off the couch for 3 days. Our facility does have a vaccine mandate. Leah just asked if we had a mandate for our healthcare workers. Yes, we do. In the health system I work for now, the vaccine mandate is, I think, mid this month, the 18th maybe, something like that. Everyone will be mandated to be vaccinated, and they're telling people that if they're not vaccinated by the 18th, they will be removed from the schedule, and then until they're vaccinated, and then if it goes beyond that, then they are releasing folks. So we'll see how that plays out in the next couple of weeks, just to see what's going on. As far as I know, our whole RD team is vaccinated, so this region is west of the mountains, so we are Western Washington. We have about 5-6 hospitals over here, and then a few over near Spokane and Idaho. And our whole RD team on this region, so there's about 40 of us, I think we are all vaccinated, so that's nice. I won't be losing any coworkers. The long-term care facility that I was working at didn't have a vaccine mandate at the time that I was there, but they highly encouraged it. Our director of nursing was really passionate about making sure we keep our residents safe, which was great. And then, steps were taken to isolate the people that were ill so that we didn't spread it all over the place. We shut down units, we shut down visitors. The facility I worked at was a continuous care community, so we had everyone from hospice, skilled nursing, up to, we had rehab, then we had independent living, and we had assisted living as well on our grounds. Another one is, do you see yourself staying in the clinical for the time being? What's my dream RD position? Honestly, I really love clinical. I think that it's where the pace is crazy, but I need that pace to kind of keep myself sane, I think. I've been in long-term care. The main reason I left long-term care this time around was I was just getting bored. I mean, it's the same patients, it's the same comorbidities, it's the same interactions every week, every month, trying to convince the same patient who's high risk, who keeps gaining weight, they're starting to lose mobility, having the same conversation with him about, let's not drink all that soda. And that's the downside, is that it's the same thing, and I was getting bored. And I think long term, I would really love to just be ICU and nutrition support. I think that's where I really enjoy it. I also love the education side of it too, though. I like to patients and kind of problem solve with them and get down to the bottom of what's actually causing their issues when it comes to nutrition. The health system I work for now, it's great now. I have small children, well, school-age children now, I guess. My daughter started kindergarten this year. But it's been nice to work on call so that I can kind of create my own schedule. I've been doing a lot of extra hands shifts this last month or so during this last surge, just as being support and taking some of those patients off of our ICU dietitian just so that we can function and not get so overwhelmed. Our charting has changed drastically because we're not able to devote the time and energy that we need to, or that we'd like to. We're all in ICU care because we want to do a great job for these patients and make them, help them get better and give them the best care that we can as far as nutrition's concerned. And it's frustrating when there's too many patients to be able to do that. So I've definitely been providing some support, helping out when needed. Another question. Some dietitians get frustrated with MDs. Do you have dietitians who don't understand the role of the RDs? How do you deal with this? I would think that's meant to say, how do you have physicians that don't, or providers that don't understand the role of RDs? I have had a doctor look me straight in the face and say, "Are you a dietitian?" And I was eligible. I hadn't passed my test yet, but I was like, "Well, I mean, I'm, nutrition." And he goes, "Oh, so you deliver trays and you take food orders." And I was like, "Well, I can do those things. I don't regularly do those things." And so just having that conversation, which was a really odd exchange, but for him to understand that, yes, we do make recommendations for TPN and enteral feeding and, vitamin supplementation and those kinds of things. And it was just really odd. And I think our ICU dietitian that we have, the primary ICU dietitian right now at our facility, she does a great job of really advocating for the patients. And she's an older dietitian. She's been a dietitian for like 20 years, but she very much educates our providers and makes it a little easier for the rest of us, for sure. It's a lot of finding the research to back our recommendations if we're having pushback. I think finding, the Aspen paper or another medical journal position paper or recommendations or whatever it is, finding that to back up what our thoughts and recommendations are, I guess, and helping push them along a little bit. I think it's been a struggle for me. I have a doc right now who I deal with on a regular basis. He is a DO, so a doctor of osteopathic doctor. He is a provider in our hospital who I've figured out has a weight bias issue. So that's been difficult for me to deal with. Trying to get it to fight him on over-restricting patients. I had a patient who was on a low-sodium diet, was on a regular diet, ordering like 3,000 to 5,000 calories a day. And I had estimated her needs around 2,000. And I had shared that with a doctor because he wanted to over-restrict her, putting her on a carb control or whatever else. And I was like, I can't justify that. She doesn't have diabetes. There's only thing that I can justify is a low sodium diet. So we can restrict that, but I don't need that. But his response was, well, I'm 180 pounds and I only need about 1,800 calories. So no way does she need 2,000. So that is frustrating in the fact of, yes, we're trying to make sure that these patients are getting the care that they need, but also just because someone is overweight and sick does not mean that we need to fix their weight problem. That's not their primary issue. It may not be helping their primary issues, but our job is to make sure they're getting adequate nutrition, they're given the tools that they can to move out in the community. Any other questions today? Concerns? Things you want to know? What are your thoughts on long COVID? It seems we're going to be dealing with these problems for quite some time, and many have nutrition implications. Absolutely. I think long COVID is pretty devastating. The debility is staggering. We have a lot of people in our inpatient rehab in the facility that I work at that their issues are from complications of COVID. Some of them were fine. They didn't have to be hospitalized during the pneumonia portion of their illness, but then they had a stroke or neurological symptoms or things like that that's taking a lot more of our resources as far as debility goes. So making them stronger and then putting people out into the community. So we have a lot of people who are stuck in the hospital because we don't have a safe discharge for them. We don't have the beds available in rehab. We don't have the beds available in the community skilled nursing facilities or adult family homes or anything like that that we would typically place our patients with. They don't have the staff to deal with a patient who's debilitated, or we don't have the numbers available. So I know there's some people, they're placing them like out of state because that's the only LTAC they can find because now this patient is trached and pegged. So it's really putting a strain on the healthcare, not just in acute care. It's going to be a long-term care, and with I totally forgot. Lost my train of thought. Sorry, guys. My ADD is in full force this morning. It's going to put a lot of pressure on our system as a whole, and it puts you at high risk for comorbidities. With the blood clots that we're seeing, with the neurological symptoms that we're seeing, and even with chronic or with a significant illness like COVID pneumonia, you're getting those things that are opening, those traumatic events that can open up autoimmune disorders or something like that. So I think we're going to be dealing with COVID for a while in and of itself, and then, the long-term effects of that are going to be interesting to see what will become of the healthcare system and what the changes that we're going to have to make and adapt to further support these people long-term. Thanks, Leah. All right, guys. That is it for me today. Like I said, I'm always here. You'll see me poking around, adminning stuff, but I'm happy to chat if you have questions about whatever, internships, acute care, that kind of thing, where I can find resources. I'm happy to help. Shoot me a message or whatever. So I hope you guys have learned a little bit about me and about what we're doing in long-term or in acute care. And then, tell your friends to mask up, get their vaccine. It's a slog out here. So take care of yourselves, stay safe, and I'll see you soon.